All right, today we're doing something a little different. We're not just looking at textbooks. We're going to crack open two real, urgent, and complex medical case files. We're going inside the renal case files to see how doctors have to make these incredibly high-stakes decisions when the kidney is in crisis. Let's jump right in.
So we've got two patients, two full-blown emergencies, and one organ, the kidney, is at the center of it all. In one case, it's a systemic attack, the body literally turning on itself. And in the other, it's more of a plumbing problem, a critical blockage that's threatening the whole system. These two cases are going to reveal some really fascinating and honestly counterintuitive lessons in medicine.
Okay, let's open the first file. We're calling this one a systemic attack. And trust me, that name fits perfectly. We are about to see an immune system that has gone completely rogue, launching this devastating assault on its own body, with the kidneys right in the crosshairs.
So let me introduce you to our patient. He's only 28 years old. For about 3 weeks, he's just felt wiped out, really unwell. But in the last couple of days, things have taken a terrifying turn. He's struggling to breathe, and now he's coughing up blood. I mean, that is a massive alarm bell that sends him straight to the emergency room.
The first labs come back, and whoa, the story they tell is pretty grim. His blood pressure is jacked up. His hemoglobin is way down, which means he's anemic. But the real shocker? Look at his creatinine. At 311, that is way, way out of the normal range. It's basically a siren screaming that his kidneys are in serious, serious trouble. And the urinalysis backs that up. It's just loaded with blood.
Okay, so let's piece these clues together like a detective. We've got bleeding in the lungs, we can see that on the x-ray. At the exact same time, we have this aggressive attack on the kidneys, confirmed by that sky-high creatinine and these things called red blood cell casts in the urine. Think of those casts as little tiny molds of the kidney's plumbing. They're proof positive that the fight is happening inside the kidney itself. This isn't one problem. It's a war on two fronts.
And that is a million-dollar question for the entire medical team. This isn't just a lung issue, and it's not just a kidney issue. It's a systemic disease. So what in the world could be hitting both the lungs and the kidneys this hard at the same time?
This is where one specific blood test changes everything. The results come back, and they're positive for something called CANCA. And let me tell you, this isn't just another clue. For the doctors, this is the smoking gun. This cracks the case wide open.
So what the heck is ANCA? Well, it stands for anti-neutrophil cytoplasmic antibody. But what you really need to know is this. It's an antibody that shouldn't exist. It's a rogue agent that tells your body's own immune cells to attack the walls of your small blood vessels. It's a condition we call vasculitis. And where do you have tons of critical small blood vessels? You guessed it, the lungs and the kidneys. And that leads us to the final verdict. With that positive ANCA test, plus a kidney biopsy that shows severe damage right at the filtering units, the diagnosis is clear: granulomatosis with polyangiitis, or GPA. This is a very serious, life-threatening autoimmune disease, and the clock is ticking to save this young man's organs.
Now, when you're fighting a war this intense, you need a two-phase strategy. First up is induction therapy. Think of this like the initial all-out assault, the shock and awe campaign. The only goal is to stop the attack and put out the fire right now. Then, once things are under control, you shift gears to maintenance therapy. That's the long-term lower-dose plan to keep the peace and prevent the fire from ever flaring up again.
For our patient, there is no debate. It has to be immediate, aggressive induction therapy. We're talking hitting the immune system with the big guns. High-dose steroids given through an IV to slam the brakes on inflammation, plus a really powerful immunosuppressant like cyclophosphamide to shut down the factory that's making those rogue ANCA antibodies. Using milder drugs, that would be like bringing a squirt gun to a 5-alarm fire. Just way too slow.
Okay, let's close that file for a minute and open a new one. Case 2 is a totally different beast. We're going from this complex immune system attack to something that's, well, it's basically a plumbing problem.
So here's our second patient. He's 64, and he's had high blood pressure for a while. But here's the kicker. It's now completely out of control. And get this, he's already on 4 different blood pressure medications. When you see that, what we call resistant hypertension, you know something else has to be driving this.
The physical exam turns up a huge clue. The doctor listens with a stethoscope over his side and hears this whooshing sound. It's called a bruit. That's a sound of chaos, of turbulent blood flow in an artery. Then an ultrasound confirms their suspicion. His right kidney is way smaller than his left. That asymmetry, plus that crazy high blood pressure, it all points to one thing: a blockage in the blood supply to that smaller kidney. So they do a more detailed ultrasound to see exactly what's going on, and the number they find is staggering. Over 80%. That's an 80% blockage, a stenosis, in the artery that feeds his right kidney. It's literally being starved of blood. And that is our diagnosis: severe atherosclerotic renal artery stenosis. Plaque has built up and clogged the pipe. And what does that poor, starved kidney do? It panics. It starts pumping out hormones that tell the rest of the body, hey, we need more pressure. And that is what's driving his blood pressure through the roof.
Okay, so the logical next question here, right? If there's a clog in a pipe, you unclog it. In medicine, that often means putting in a stent. So why not just go in there, pop a stent in, and open up that artery? Seems like a no-brainer.
And this is where medicine gets so incredibly fascinating, because your gut instinct is wrong. We have these huge landmark clinical trials. Astral and Coral are the big ones. And what they found completely changed how we think about this. They found, and I'm going to read this directly, no significant benefit of stenting over medical therapy for most of these patients. No real improvement in blood pressure, kidney function, or even preventing heart attacks.
So what does that mean? It means the right move, the evidence-based move, is actually to stick with the medications. You fine-tune them, you optimize them, including a crucial drug class called an ACE inhibitor. You just have to monitor his kidney function very closely. You're managing this plumbing problem with pharmacology, not hardware. It's wild, but it's what the science tells us to do.
All right, so let's put these two files side by side. Two patients, two totally different kidney emergencies, and two very different paths forward. What are the big lessons here?
This just lays it all out, doesn't it? In case 1 with the autoimmune attack, the right call was to go in all guns blazing, with powerful drugs to stop the body from destroying itself. But in case 2, with the blockage, the right call was to pump the brakes, to resist that urge to do a procedure and trust the evidence from medical management. The big takeaway? You have to know what you're fighting before you choose your weapon.
And you know, that really leaves us with this big, final question, doesn't it? It goes way beyond just these two cases. When we're faced with any problem, really, how do we balance that powerful human urge to do something, to intervene, with the hard evidence that sometimes tells us the smartest and bravest move is to do less? That's the art of medicine right there. Thanks for digging into these files with me.